speaker.
Can I now call upon Dr. Abhay Bhave, who is a very, very well-known hematologist, very simple person, very approachable, and always there to give advice on any hematological emergency which we encounter. And I cannot find anybody else than Dr. Bhave to give a talk on this topic of unmet medical needs in use of oral and injectable iron in the management of iron deficiency anemia. May I present to you Dr. Bhave, please.
Thank you so much, madam. It's one of the most beautiful introductions I've had. It's so sweet of you. Thank you. I thank the organizers for the opportunity to interact with you on this topic of unmet medical needs in IV and oral iron therapy. I'm sure you know the kind of burden of anemia that exists in our country and worldwide. The statistics are there for you. What is damning is that the class of people who are responsible for our future, they are 60% of the times affected by anemia. And for the pregnant woman who is anemic, there's a good chance that she'll land up in trouble 20% of the times with mortality. Mortality, 20%. And 50% of the times anemia is a contributor to some form of morbidity or mortality during pregnancy. So these are damning figures. You name the type or the site or the stage of pregnancy throughout, whether it's antepartum, intrapartum, postpartum, and for the fetus. The implications are wide as far as anemia is concerned. And therefore, anemia as such a simple thing is such a big problem still. It's unbelievable despite all the policies that the government has got for so many years. We are still discussing anemia in 2020. So there are several causes of iron deficiency because that's the bulk. 50 to 60% of times anemia is because of iron deficiency. There are many causes that you can see over here, but pregnancy is one of them which is physiological, in which iron deficiency gets even worse as the gestation goes on. And today, we've got women who are surviving all kinds of other diseases or other clinical conditions, surviving, getting pregnant and going on towards having a child. And in them, there's also a different other problem. So if you classify anemia, everyone knows that hemoglobin of 11 first trimester, 10.5 in the other two trimesters is what below that is considered as anemia. But the one which we are worried about is 7 hemoglobin, because below 7, the dictum is to give transfusion. Bring up the hemoglobin because it adds to the morbidity and mortality of the child. So that's why we are supposed to be very active in order to bring up the hemoglobin once it touches 7. The issue is, why did we let it go till 7? Because people come to us late. It's not that we are not doing anything. They come to us late. They come to us later in ANC. They register late. And that's why it's a problem. This from what I've understood from my interactions with obstetricians in the past. But when they have come to us in time, still we are not doing enough for them, I think, to be able to alleviate this anemia. So 7 is my cutoff, but anywhere in between is considered to be mild and moderate. 7 is severe. And the commonest type of anemia is iron deficiency, and it presents to you on a CBC as a hypochromic microcytic anemia. But don't be fooled by it, because hypochromic microcytic anemia has other differentials which I've shown you here. And one of them is a lurking fear and a dangerous one called beta thalassemia. And if you miss that beta thalassemia, and the mother is beta thalassemia, and so is the husband, there's a 25% chance that the child growing will be thalassemia major. And can be a major problem for you when the child is born. Because if it's a major, then they'll say that you did not do the test, that's why the child is born as a major. So don't be fooled always that all hypochromics are, microcytics are iron deficiency. Keep a watch on thalassemia. So how do you do that? If you've got all 5, hemoglobin, MCV, MCH, MCHC, and the RBC count, all 5 are low, this is likely to be iron deficiency. The moment 2 features, RBC count and MCHC, are normal or high, please remember it could be thalassemia. Do the test, and if it is positive, do the husband's test. If it's negative, you don't have to worry about the husband, but if she's positive, do his also. And if both are positive, you still have the chance to do a coronary Willis biopsy or amniotic fluid cell analysis to see whether the growing fetus is major, normal or minor. And that will save a lot of trouble to everybody, that family, that young family, and also you. So before we talk of iron deficiency anemia, there is something called as iron deficiency state. Means anemia hasn't come in, but the patient is iron deficient. Many times we miss it, and please believe me, iron deficiency state is 3 times more common than iron deficiency anemia. We are picking them up in anemia. They are actually iron deficient to begin with. That's why if you'll notice all the WHO, our ministry, and apna own Foxy, they've all said that give iron therapy to all patients who are pregnant. Why? Because iron deficiency state is very common. So if you treat them and the hemoglobin responds, you've taken care of them before they go into anemia. So that's very important to realize that you can pick these patients up. So many of the young couples who are coming to us and they're desirous of getting pregnant, and they come for various reasons other than pregnancy at that point in time. We do analyze their hemoglobin and see whether there's any correctable cause that I can bring up the hemoglobin, so that their life will be easier during pregnancy and they don't have to run from pillar to post trying to bring up the hemoglobin at the last minute. And certainly you and me don't want to give transfusion to them. That's the worst thing we can do. Transfusion is it's like putting petrol into a car. It's so temporary, it's so fraught with all kinds of problems that we should not be doing it. But in order to not do it, they have to come to us in time. Then we have to have awareness, which is why I thank the organizers for keeping our talk in this kind of a setup so that I'm able to express myself to you. You'll realize that if you want to diagnose iron deficiency anemia, the best is to do ferritin. I know you all do serum iron studies because it's cheaper, it's easier, and it's rote. It's part of your thinking. But can I request you to do ferritin, because all papers of iron deficiency anemia are based on the ferritin levels. And I'm giving you reasons why ferritin. It's stable. It is not affected by the recent iron ingestion. Serum iron studies are affected by it. And it's a very a molecule which is associated with good amount of sensitivity and specificity, especially if it starts going below 15. The sensitivity and specificity is really high for diagnosing that this is iron deficiency. So there are several things we can have to correct the iron deficiency anemia. So we've got oral preparations, we've got IV preparations.
Nilima.
This is a mobile phone on? Okay.
Probably.
So there are several such preparations which are available, including the intravenous. And I know you and me are using more and more of intravenous because our patients can't handle oral iron preparation. And I'll tell you reasons why they may not be able to handle it. But look at the number of preparations. If you see, look at the SIMS and MIMS, there are some 180 preparations of oral iron in combinations or alone. And therefore, we are spoiled for choices. But the problem is, everything depends upon the bond between the iron and the salt. If the bond between the iron and salt, there's some program going on somewhere else. If there is a weak bond between the iron and the salt, in the gastric acidity, the bond breaks and the iron is released into the stomach. So you immediately get gastritis and the patient starts complaining of pain, constipation or diarrhea, and therefore the compliance is very poor. So they stop taking the iron preparation, which is the problem, because here we've got iron deficiency. On the other hand, they are not able to tolerate and the compliance is poor. So somehow we have to overcome this limitation. Now the limitations of this oral iron preparation are poor absorption, higher side effects because of release of free iron, and because of these GI effects, there is poor compliance again. And then because of that, there is poor efficacy, because you're giving iron, supposedly, patient is supposedly taking, but there's no response. So in this situation, is it possible that we can use something else? Obviously, the next thought is IV iron, and it's brilliant, it works well. But in my discussions in the last 1 month with obstetricians around Mumbai, I've realized that there are fears, and the fears are of reactions, the fears of sometimes having to admit these patients because they are not well, they've had the side effects which need admissions. So there's a fear also. So you keep wondering, is there something else that we could have got other than IV, which is also very expensive? So it'll be nice if you get a game changer. Now, what's a game changer? Let's look at the absorption of iron. You'll notice over here that iron gets absorbed from the lumen. Can you see the arrow? Yes. It gets absorbed from the lumen. Either it is heme form or heme form or non-heme form, that is non-vegetarian or vegetarian. Comes into the mucosa through two different ports. These are rate-limiting ports. Comes inside, goes through another one which is called ferroportin, which is the final authority to allow iron to come into the bloodstream. It goes into the bloodstream and is utilized by the bone marrow. Part of it also goes to the liver. And once it's stored in the liver and there's adequate stores, there's a new protein called hepcidin which comes up. And the hepcidin is the one which regulates. So hepcidin is a negative feedback on the ferroportin. Now during pregnancy, this hepcidin might go up as part of an inflammatory process. Which means during pregnancy, Hepcidin, if it increases, it will prevent this ferroportin from taking iron, so you get an iron deficiency, which is why people end up taking iron therapy. So it's a rate limiting step in these cases. Yes, there is IV iron. It's changed the way we treat. We've got 3 preparations available for us. But it comes with issues. And those issues sometimes are real. Last time we had a discussion in Mumbai, one of them said that after IV iron, there was a drop in the fetal heart rate and she had to deliver the child. So I hear a lot of these things happening. They are not common, not at all. And I would strongly recommend that where people have been counseled well, the need is good, we must give IV iron, because I would rather use IV iron and bring up the hemoglobin than give blood transfusion, which has got lots of hidden things which we don't know come up later on. So therefore, I would love to use IV iron. But you have to use it with counseling and you have to tell them, and please do the serum ferritin. Please do serum ferritin before you give IV iron. Document that the level is less than 50. For pregnancy, it should be less than 50 microgram per liter. If it's there, yes, then you are valid to use it. And as a result, you would want to keep IV iron for those people who are not responding to oral, who don't want transfusion, and you want the hemoglobin to come up rapidly. So there's an unmet need, and if that unmet need can overcome hepcidin, can overcome side effects, and can be as good as IV iron or safer than IV iron, nothing like it. So there is something called sucrosomal iron. There is a huge amount of documentation on it. There are 12 full-length published articles in peer-reviewed journals. Number of patients have used it, more than 6,000. It's a pyrophosphate in the center, iron pyrophosphate, and it is surrounded by a matrix, which is called as a Sucresta matrix, which protects the iron and does not allow it to be dumped in the stomach. Therefore, it gets a good tolerability, good bioavailability, therefore good absorption. And its method of absorption is unique. I'm going to show it to you. And that's why it fools hepcidin, it fools the method of absorption, and that's why it is called as a molecular Trojan horse. Only thing is, this Trojan horse goes inside to do good rather than to damage the opposition. So in this situation, I would say that it's a game changer. Its mechanism of absorption is threefold. It is through the mucosa, it is between the mucosa, paracellular, and is also through the M cells, which go directly into the lymphatic circulation. So it has got a different drug delivery system. So the molecule is differently presented, absorbed differently. And because it is not going through routine, 2 additional ways of absorption, it can fool the hepcidin and get inside and still make you replete in a woman whose hepcidin is high because of pregnancy. So if hepcidin was trying to fool us, we fool hepcidin with this. It's effective. You can see that the growth of hemoglobin is about 4 grams in a matter of 6 weeks, which is as good as what you would get with other products or IV iron, with the fact that you can take it sitting at home. In this conclusion was that it is as effective. And in another one, when it was compared with IV iron therapy, also it showed that it was quite favorable in terms of its response. So what are my take-home messages or conclusions for anemia in a pregnant woman? We account for a large number of patients who have got iron deficiency. It is one of the iron deficiencies, the commonest among all the anemias. 50 to 60% of the times will be iron deficient, which is why randomly iron is given to our women who are pregnant, because most of the time it might work very well. Its early detection is important because you can pick up that iron deficiency state before it becomes anemia. Severe anemia and iron deficiency anemia has severe implications in pregnancy, from morbidity to mortality. And if you don't want a small child, or an IUGR, or an IUFD, which has been reported with severe hemoglobin, especially less than 6. Detecting thalassemia is extremely important. You don't want to miss out the opportunity. We would love to avoid transfusions. We never know what comes up next. And if they get HCV or HIV in the future, they'll say, you're the doctor. You should have said no to transfusion. I may have asked, but you should know. You're the doctor. You should have not given it to me. So they'll turn around and tell you that you should have not given it to me. So please be very careful with transfusion. Oral iron therapy, I have no doubt in my mind, is a cornerstone for the treatment of iron deficiency. But this stone is hard to turn. It's difficult sometimes. The women don't take it, and it's a problem for us. And IV iron is always there. Yes, it comes with caveats, cost, safety issues and all that. But it's not very rare. And for those who can afford, it's a brilliant product to use. But if you get an oral novel therapy that can help, why not? Something which is safe and cost effective sitting at home, nothing like it. Average cost of IV iron therapy will be about 5,000. And therefore you can save that by taking oral tablets, nothing like it. So I would say sucrosomal iron is there for us. It's a novel preparation, unique drug delivery, good bioavailability, good absorption, and therefore this is something which we're always looking for. So have we met the unmet need? Time will tell, because we are doing a study. The Gynaecologist Society of India is doing a study, multi-centers across India, to see how this preparation works. And if it works, nothing like it. It comes in 30 milligram. But if you can use up to 4 capsules in a day and bring up the hemoglobin, nothing like it, you can replace IV iron. And I wish all the best for our pregnant patients, that if they can use this and do well, we'll be very happy. Thank you for your attention. And I'm sorry for the 1 minute and half beyond.
Thank you very much, Dr. Bhave. It was very enlightening and very insightful. That sucrosomial iron, it's really a good way of, giving oral iron. And I'm sure that this will be a good message for all of us.
Thank you.
To try with oral first and then maybe with iron, and never, ever blood transfusion for
only for emergency.
Yes. Thank you so much for giving your thoughts on this. Thank you.
Thank you.